Hello and welcome back to the Oncology Brothers podcast. I'm Rahul Gosain and I'm here with my brother and co-host Rohit Gosain. We're excited to bring you the latest conference highlights from the annual ASCO 2025 meeting. Though thousands of abstracts were presented here, we've picked 5 that are potentially practice-changing in the world of lung cancer. For this, we're joined by Dr. Stephen Liu from Georgetown Lombardi Comprehensive Cancer Center. Stephen, thank you for joining us. What an exciting ASCO.
Yeah, thanks for having me. Always a pleasure to see new data as it comes, but also to see how we as colleagues react to those same data sets and what impact they have for our patients. Always a very interesting and engaging meeting.
Indeed. Let's see how our lung cancer world has changed. Stephen, for the next 20 minutes, we'll dive into 5 key studies from lung cancer, starting off with non-small cell lung cancer, updates on CheckMate 816, and then timings of immunotherapy, rather a very interesting study. And thereafter, we'll shift gears into EGFR-mutated space with NeoADAURA, and then finally talking about the exciting space of small cell lung cancer, where we'll touch on IMforte and DeLLphi 304. So let's dive into our first study, which is CheckMate 816. Can you briefly touch on the study design and findings? What I truly want to know is, though we have overall survival data here, when am I using neoadjuvant perioperative approach? What are we doing here?
I think we'll need more than 20 minutes to cover that. This was the original New England Journal paper led by Patrick Ford. The journey from concept to where we are today, an overall survival benefit is well over a decade. This was a randomized study for patients with currently resectable stage 1B to 3A non-small cell lung cancer. This was using staging system 7, and we're already well into staging system 9, just to show how much time has passed. Patients were resectable at the time of entry and were randomized to a standard of care, which would be neoadjuvant chemotherapy here, platinum doublet chemotherapy for 3 cycles, or chemotherapy plus nivolumab, the PD-1 inhibitor. The addition of nivolumab significantly improved the likelihood of pathologic complete response, improved major pathologic response, improved event-free survival. And we've learned sort of a lot about different subsets, the potential impact, long-term event-free survival, and always trends towards the improvement in survival. And then we look towards the perioperative space where we had seen neoadjuvant, followed by surgery, followed by adjuvant or consolidation immunotherapy led to improvements in overall survival, in addition to EFS and PCR. So one question we had was, for this neoadjuvant alone, do we see a survival difference? Well, these are event-driven. This is a smaller study, and there are lots of different circumstances here. But we saw at ASCO 2025 that indeed the addition of nivolumab to neoadjuvant chemotherapy did improve overall survival. The improvement in survival here has a ratio of 0.72, crossing all of our metrics for what we consider a significant improvement in survival. If we look at landmark survival at 5 years, 55% versus 65%, I think it's a significant difference. We also did see an update with longer follow-up on event-free survival there. That has ratio 0.68 there. That 5-year EFS rate, 49%. To be cured, you need to be event-free. So we are curing more people. People are living longer, and that does lead to sort of changes in practice, improvement in survival. When we look at these data, how do we interpret it? We look at certain subsets that I think were important. If you achieve a pathologic complete response, those patients did remarkably well, whether with chemotherapy or with nivolumab chemotherapy. It's just that with nivolumab and chemotherapy, it's much more likely to get past CR. But the PD-L1 expression data are consistent and compelling. PD-L1 positive, we saw a powerful benefit. The OS hazard of 0.51, but PD-L1 negative, 0.89. Not powered to show those differences, but the differences, I think, are pretty clear. The question you asked, though, is the one that we see with our patients. When do you need that adjuvant component? Neoadjuvant, I think, is now our standard for resectable stage 2-3 non-small cell lung cancer after discussion in the multidisciplinary team, after looking at mutation status. But really, that adjuvant component, we need more data because these studies were not designed to answer that question. Today, I think someone who had a pathologic complete response, I would be very comfortable not giving the adjuvant component. The survival benefit was the data we needed to have that confidence. If they were PD-L1 negative, I think the likelihood of cure is lower. I would probably offer adjuvant immunotherapy. I don't know if adjuvant immunotherapy improves the likelihood of cure in that group. We need more studies, and there are some going on now in Europe and the US. Certainly, if the patients were not comfortable stopping therapy after discussion, patient preference plays a role here. Patients were interested in continuing as long as I felt it were safe. I do have comfort or equipoise continuing therapy as well.
Stephen, is there any role of ctDNA outside clinical trials in this setting?
I think there will be. I think when we look at these MRD assays, and there are several commercial assays that are tumor informed, seem to be providing some real value in other disease types. I think the data in lung cancer is not quite as strong, not quite as robust. Certainly, it's where the field is going, but I don't know that we're there yet. Do I have enough confidence in these assays? Are they sensitive and specific enough for me to make treatment decisions? I think they can add some information. I think today, though, they probably have more questions than answers. If that continues to develop, I'm starting to get a little experience with these assays, but I think the data is not quite there yet for lung.
Absolutely. All right. We've covered so far CheckMate 816. I'm moving right along to another study. This one got me. Stephen, we ran into each other during ASCO, and I had shared that concern. We're seeing a profound benefit in patients that received immunotherapy earlier during the day. We're talking about significant overall survival as well. This is a positive study, but the degree of benefit here is astounding, and I'm not sure if I can wrap my head around the science behind this. Stephen, can you touch on this and its findings?
Yeah, I was right there with you. And like we said before, I think this needed a bigger platform and more visibility. This was huge.
Indeed.
This was a prospective study conducted in in China and France that looked at patients with advanced non-small cell lung cancer receiving chemotherapy with immunotherapy. In this study, patients were randomized simply to time of day for infusion. It was before 3 p.m. or after 3 p.m. Very simple randomization, no stratification, no subset analyses, just a simple stratification to time of day, looking at PFS. And what they showed was a pretty profound improvement favoring earlier infusions. The PFS here showed that if you received it early, median progression-free survival, 11.3 months, versus late, 5.7 months. That's a hazard ratio of 0.42. Now, I understand that we want to look at subsets, PD-L1 high versus negative. Overall, things are going to be balanced in a randomized study like this, but there are certain things we certainly want to consider, looking at mutation status and so forth. But an effect size like this, with a very simple, really no-cost intervention to have a PFS benefit of 0.42, to have curves that split immediately, widen over time, this caught all of our eyes. And what was even more astounding was it translated to a survival difference. The overall survival hazard ratio is 0.45. I think the science here is still unclear. And there have been a lot of retrospective studies with both immunotherapy, chemotherapy with radiation therapy, showing similar things, that earlier time of day seem to offer better outcomes. And it has something to do with the differences in our immune response, anything involving immunogenic cell death with our circadian rhythms, but something that is incompletely understood. With a drug that has such a long functional half-life, why should it matter what time you're giving it? And I think it really is the initiation of that immune response. I think in this study, they did collect a lot of circulating immune markers and showed differences in circulating CD8 positive T cell exhaustion. It shouldn't have a difference. It shouldn't matter, but it seems like it does. I think a humbling reminder that we understand very little of how our immune system works and all the different things that factor into it. We often speak of the microbiome, and we look at the profound impact that microbiome has on our immune responses, and yet to this day we still don't control for it, even analyze by microbiome. Now do we need to go back and look at all these positive and negative trials, and are we really seeing differences in interventions or simply differences in time of infusion? Is the reason that early phase trials look so good because you have to do so many long PKs, so you have to start in the morning for an 8-hour day? And is it something as simple as that? And while we do need to confirm this, we do need to understand this, really how it applies at an individual level, and what is time of day really a surrogate for. While we need to do all of that work, I got to tell you, nothing is stopping me from changing the time of infusion immediately.
The Rahul is still a bit skeptic, but I'm definitely moving forward with this in my practice tomorrow itself. Okay, now moving along in an EGFR-mutated space. For EGFR-mutated disease, we have osimertinib in adjuvant setting for 3 years based off of ADAURA trial. At ASCO 2025, what we saw was phase 3 NeoADAURA. Stephen, could you please touch on the study design? And are you ready to adapt this in your practice? The question really is, now we have ADAURA in adjuvant setting and this separately in neoadjuvant. What are we doing?
These are patients with resectable non-small cell lung cancer with an EGFR mutation. When we think of using TKIs, we might think this could make surgery easier. While that may be true, that's not what this study was. This is resectable lung cancer with an EGFR mutation randomized to osimertinib alone, osimertinib plus neoadjuvant chemotherapy or neoadjuvant chemotherapy, followed by surgery. And then afterwards, patients had the option to continue adjuvant osimertinib. I think that became standard of care while this study was ongoing. The adjuvant component obviously isn't going to impact any of the surgical or pathologic outcomes. And what we saw here that I think was outlined very clearly is that, osimertinib does induce response. If we look at pathologic response, major pathologic response, it was about 25% with osimertinib. Adding chemotherapy didn't really change that. It was 25% with or without. Osimertinib's doing the heavy lifting. Chemotherapy alone, the major pathologic response rate, only 2%. The pathologic complete response rate was pretty low, 4 to 9%. Numerically, actually higher with osimertinib alone, but I think it's just the statistics of small numbers and sample size here. Pathologic complete response rate not as common in this setting as it was with chemoimmunotherapy. It's natural to compare this to our CheckMate 816, to our Keynote 671, to our CheckMate 77T experience, but this is a different setting. And there are still a lot of questions. Does pathologic complete response rate here mean the same thing as it does in CheckMate 816? In CheckMate 816, if you have a path CR, you may not need any further therapy, and I think the chance of long-term survival is quite good. Is it the same here? And do we have the ability to stop therapy afterwards? I will admit to you, I'm not quite ready to make that leap. I do think that the survival benefit with adjuvant osimertinib seen in ADAURA is too profound to gamble with. Right. I'm not ready to interpret a path CR here, meaning you're done with therapy. To me, people are going to get the adjuvant osimertinib, whether neoadjuvant is given or not. If I've already decided that 3-year adjuvant osimertinib is going to benefit my stage 2-3 resected non-small cell lung cancer with an EGFR mutation, if we're doing 3 years, does this early part really make much of a difference here? I don't think there's going to be an EFS difference. I don't think there would be an OS difference comparing this to just an adjuvant alone strategy. I think this is very interesting. We can learn a lot about persistent cells, how cells survive neoadjuvant osimertinib, give them osimertinib, see what survives, understand how it survives, modify our therapy as a research platform. In standard practice tomorrow, I think I would just send patients to surgery and give adjuvant, but I'm not sure if your approach would be any different.
The reason why you bring that up, Stephen, is because we have overall survival benefit from ADAURA, right? And then we're talking about, is this really any different of disease? And we see this with Pacific and LAURA comparison. In Pacific, we're giving 1 year of durvalumab, and LAURA, we continue on with osimertinib. Is EGFR disease just lingering on? Is it a different beast with CNS penetration and so forth? We've seen that drop off of the survivor curves when that 3-year osimertinib comes off in ADAURA as well. For me, this is good, but ADAURA is still going to be my standard of practice right now. What I'm walking away from this study is the importance of NGS in early stage of non-small cell lung cancer. This is not changing my practice, but we should be looking for these actionable mutations, be it for EGFR or ALK. All right, now let's shift gears to small cell lung cancer. Finally, not just one, but we have 2 studies showing overall survival benefit in this devastating disease where outcomes in the past have been for months. Starting off with IMforte, Stephen, can you walk us through the study design and its findings?
Yeah, I was happy to be involved with this study. This is a trial looking at maintenance therapy. Maintenance has always had a logical appeal to us. When we think of how we treat small cell lung cancer, we give induction. These days, we also give with immunotherapy, either atezolizumab or durvalumab, and we expect a response. Not everybody, but we do expect a response. Then we expect relapse, and then we move on to second-line therapies. The challenge with that transition from frontline, progression, second line, 1, patients are often very sick when they move on to second-line therapy. 2, our second-line treatments historically haven't worked that well, and many times the act of progression itself is a fatal one or a devastating one, such that in most series, 50 to 60% of patients never get second-line therapy. The data are strikingly consistent over decades. It's an unforgiving disease, and if you wait till progression, sometimes patients won't be well enough or won't survive that act to receive any further therapy. So why not move things earlier? Why wait until progression when we could give things early in a proactive way as a maintenance strategy? IMforte is a maintenance trial. Patients receive frontline chemotherapy plus atezolizumab. For patients that do not progress and are still well enough, They are then randomized after induction to receive standard atezolizumab maintenance alone or atezolizumab with lurbinectedin. Note lurbinectedin given with primary prophylaxis for neutropenia, because that is an important toxicity. When we add an active drug, which lurbinectedin is, what do we expect? We expect an improvement in progression-free survival because we're giving that second-line therapy earlier. We're giving an active drug earlier. So we would expect an improvement in PFS, and we saw it. The PFS improved from 2.1 to 5.4. Those numbers seem low, but remember, they're being measured from the end of induction. So you have to correct by adding 3 months to everything. But the PFS hazard ratio, 0.54. That's impactful. Not enough to change practice by itself, though. You expect to see more responses, which you did. Deeper responses, which you did. You also expect to see toxicity, which you did. Now, fortunately, it did not translate into people stopping therapy. Even though the rates of toxicity were high, they were largely paper toxicities, not really impacting patients. We can see neutropenia, but neutropenic fever was quite low. Discontinuation due to toxicity was in the single digits percentage-wise. The big question with any maintenance strategy, do you improve overall survival? Do people live longer by giving therapy earlier? That should be the measure of the maintenance strategy. Otherwise, you're just running through treatments earlier. You're increasing the time on treatment, which is not a good outcome. Improvement in PFS alone for a maintenance strategy should not be enough to change practice. It should be an improvement in overall survival. But that's what they showed, an improvement in overall survival. The median survival, again, measured from completion of induction, 10.6 increased to 13.2. The hazard ratio, 0.73. That hazard ratio was what we saw in Empower 133, in Caspian, and in Adriatic. Really the same degree of benefit in terms of hazard ratio, that 27% reduction in the risk of death with this intervention. So there are costs to it. Yes, there are toxicities. And you worry, can patients tolerate therapy? But not a lot of patients stop treatment here for adverse event. And so we don't want to go in with any of our own expectations or biases. Giving maintenance lurbinectedin here improved overall survival. And to me, this is impactful, and this would be my standard of care today.
Congratulations on being involved in this important study, which is changing the practice. And with regards to what you said, that a lot of patients are not even seeing the second line, or what we have seen also in the cases of colon, bladder, and other tumor types. I would expect in small cell lung cancer, it's even worse. Getting these patients through lurbinectedin, balancing side effects is extremely important. Talking about side effects, Stephen, could you please walk us through some clinical pearls in managing some of the toxicities here?
You got to watch pretty closely. And so while you're receiving platinum etoposide, those are myelosuppressive treatments. Patients often feel better after chemotherapy. Lurbinectedin does have toxicities, primarily hematologic in nature. I think that we do a good job managing, preventing nausea, as we do with any cytotoxic. But the myelosuppression is what we have to watch. This did involve primary prophylaxis with growth factor, and I think that should be considered part of the treatment plan. You have to watch. And while the treatment is given every 3 weeks at a dose of 3.2, sometimes we have to lower the dose. Sometimes we have to space out the intervals, and that's okay. It's a marathon, hopefully,
Right.
not a sprint. And so we have to make adjustments. We have to look at the data and stray from the original regimens whenever appropriate. Dose delays, I think, are very reasonable. And so if we see those counts are not quite where we want them to be, if we see we don't have quite the buffer that we want when we look at the neutrophils or the platelets, delay things a week. And if it's consistently happening, maybe going to a 4-week instead of 3-week. I think this really is the art of oncology and understanding our patients and balancing that toxicity with our patients. I also do have flexibility here. The purpose of this treatment is to let our patients do things. So if we continue our treatments every 3 weeks, can we push it back a week so someone can attend a graduation or go on a vacation? Absolutely. This is why we do what we do. But the bottom line is the greatest threat to these patients' health is the cancer itself. The longer we can keep that at bay, the better our patients will do.
Indeed. And with regards to growth factors, are you adding that induction or maintenance standpoint? And also, are you using trilaciclib or just growth factors?
Yeah, so I'm mostly using it in the maintenance setting, in the induction setting, while we can see neutropenia. The rate of neutropenic fever was quite low. I do think as you give more cumulative marrow-suppressive agents, the risks start to get a little bit higher. So I do like to use it in the maintenance setting, and that is how the study was done. I don't typically use in the induction setting. Trilaciclib is a drug that we haven't really used much. I think it's an interesting drug, and it certainly can help in this setting. In certain circumstances, it might be something I reach for, but as of today, it's not something I routinely use, though I would never fault someone for doing it.
Yeah, these patients are living longer, so we have to get comfortable in managing these toxicities. Any overall survival benefit in small cell lung cancer should be celebrated. Congratulations, Stephen. Because of this, our patients are living longer. And we see the similar story here with DeLLphi 304 as well. Yet another positive study in small cell lung cancer. It's about time that we're seeing some advances. Here we're talking about tarlatamab. Stephen, your thoughts. Do you envision that everyone's going to get chemoimmunotherapy with immunotherapy, lurbinectedin maintenance, and then now here tarlatamab? Can you touch on the study design, sequencing?
This was a second-line study, I think, very impactful. And I think overnight, this replaces our second-line treatment. This becomes our standard of care. This was really a comparison of tarlatamab, a bispecific T-cell engager versus standard chemotherapy. I think a very straightforward design. Patients with extensive stage small cell lung cancer who had first-line platinum-based chemotherapy with or without immunotherapy. Most did have immunotherapy. Asymptomatic untreated brain mets were permitted, and they were randomized to receive tarlatamab, a bispecific T-cell engager that targets DLL3 and CD3, or chemotherapy. And really, you had your choice between topotecan, lurbinectedin, or where available in Japan, amrubicin. The study showed very clear results. When we look at the DeLLphi study, we saw an improvement in progression-free survival from 3 points to 4.2. Those numbers may not seem so impressive. We look at the landmark PFS rates. Those curves do separate a lot more as they go further along, but the PFS hazard ratio here is 0.71. So an improvement in PFS. But again, for small cell lung cancer, we've seen that before. It's OS that's really king, and there was an OS benefit. 8.3 with chemotherapy, 13.6 with tarlatamab. That's an OS hazard ratio 0.60. Some things to keep in mind when you look at a study like this. Most patients receive topotecan. So it's mostly a comparison between topotecan and tarlatamab. Also note that topotecan really not a therapy that we would use for chemo-resistant small cell lung cancer. We know the response rate there really kind of 0%, and we would reach for lurbinectedin in that setting. So topotecan for platinum-resistant, probably not the ideal control, and about half the patients were platinum-resistant. Now that said, when you look at the forest plot, even within the lurbinectedin arm, within the amrubicin arm, even though they were smaller, you still see the same trends. Nothing would stop me from reaching for tarlatamab as the preferred second-line agent. There are some practical barriers to tarlatamab. When we think of delivery, the recommendation is a 23-hour observation overnight for day 1, day 8, day 15. Observation periods from 6 to 8 hours, then eventually 3 to 4 hours. These are long periods of time for patients, but also for our infusion units. Many units need to turn those chairs over 2, 3 times a day, sometimes more. So there are some challenges to delivery, and I think today there are more people that would benefit from tarlatamab than receive tarlatamab. But they are looking towards outpatient regimens, shortening the observations, finding other ways to give this more safely. Tarlatamab is something we give very routinely here at Georgetown, but it does require a lot of effort, a team, a real infrastructure. If this were simplified, and I do believe it will be, I think it would be much easier to implement. The immediate future for me would be, yes, carboplatin, etoposide, either atezo or durva, lurbinectedin and PD-L1 maintenance therapy. At the first sign of progression, tarlatamab. Will tarlatamab emerge as a maintenance strategy? That is a study that's ongoing. The standard will continue to evolve, continue to change, thankfully, and it's going much faster now than it has in the past. But I think it really is a day where we can celebrate these advances in survival.
Exciting times, and Stephen, as you stated, and Rahul, overall survival data in small cell should be celebrated. Tarlatamab efficacy is exciting, but CRS is still a concern. The majority of CRS, what we saw was rather grade 1 or grade 2. And as stated, logistics around this agent are the major barrier.
So one of the things we're doing is we are managing the first several doses, and once it gets to that 3 to 4 hour window where the risk of CRS is quite a bit less and the toxicities are really leveled out by then, we then transition back to the referring oncologist. The use of tocilizumab is fairly uncommon, and ICANS is pretty uncommon. Only about 6% of patients have developed it. The key is informing the patients what to watch for, and if there are worrisome symptoms, to really come back. So I think observation is going to work well, but patients probably still do need to stay in the general area of an acute center around the time.
I have to agree. As an oncology community, given we will be using more and more bispecific antibodies, we have to partner up with our tertiary care centers. We have to find good solutions to give our patients these active medications. Stephen, thanks so much for walking us through these important studies from ASCO 2025. Before we close, for our listeners, let us go over a quick recap.
In this episode with Dr. Stephen Liu, out of thousands of abstracts from the annual ASCO 2025 meeting, we had a chance to touch on 5 key lung abstracts. Starting off with CheckMate 816, we now have an overall survival benefit with neoadjuvant chemo nivolumab in resectable non-small cell lung cancer. At 5 years, 65.4% patients were alive with chemo immunotherapy versus 55% in chemo alone arm. We then also had a chance to touch on the timings of immunotherapy as a randomized phase 3 study conducted in China, which is showing significant PFS and OS improvement. To me, the true science behind this is still unknown, and I'm eagerly waiting to see more data in this space.
Rahul, and then the space of EGFR-mutated disease, which continues to see more and more changes. Here we saw NeoADAURA Trial with the use of osimertinib in neoadjuvant settings. Adjuvant osimertinib is already approved based off of ADAURA Trial, and we in fact have overall survival data here. I need long-term data from neoadjuvant approach. And then we finally saw 2 studies showing overall survival benefit in small cell lung cancer. One was IMforte and the other one DeLLphi 304. To me, my sequence likely is going to be chemo with immunotherapy and then maintenance immunotherapy with lurbinectedin and then tarlatamab thereafter. Keeping side effects for this approach and new agents is extremely important. Thanks for joining us. Make sure to check out our other conference highlights. We are the Oncology Brothers.